It's so good to see you, my friend.
Same.
We were jumping on her, full disclosure, talking about, how we first met and, finding this menopause posse of people that are really helping make this movement.
Right.
It's a movement that we're talking about. I mean, you have been, with some doctors at the forefront of this, and I'm so proud of you, first of all. Your new book, The New Menopause. How are you doing? Are you excited about it?
It's so exciting because for me, the early readers are getting a hold of it and posting on Goodreads. And it's just seeing how it's changing their lives, and they are feeling empowered and they're feeling, darn, I wish I would have had this book sooner. But that they feel like this is a powerful tool for them, for everyone they know, to help navigate this time with good information that can actually allow them to advocate for themselves.
It's so important, and it's never too late. That's the other thing about all of this, because, we come into this really frustrated that we don't have or have not had that information. And I know you've been somebody that's been out there since the very beginning. I never forget the story, though, that you've talked about women and what they were called early on when you were learning about menopause and how they were referred to as whiny women. Can you talk about WW?
Yeah, the WW. So first time I ever heard that term, I was in my residency. So I'd finished medical school and I'm in my first year of OBGYN training. And we are divided up into about half the year of obstetrics and the other half in gynecology. So we had gyne clinic, or, gen clinic, we called it. And this is how old I am. We had paper charts. And so they'd be stacked up. We'd have 60, 70, 80 patients coming in per day, and there were like 10 of us to see them. So the upper levels, the chiefs, the fourth years and the third years would run and find the surgery cases because they need to operate and get their numbers before they graduate. They'd run off and see those patients. And so that left everything else, which, discharge and gynecology issues and just kind of a catch-all of anything. And I remember as an intern, I get the very bottom, whatever's left over. And the upper levels were in charge of helping us, right? Make sure we had questions answered and how to approach these problems. And this long, tall Texan in a white coat with his cowboy boots and his scrubs, nice guy, and he said, he looked over my shoulder at the chart. He said, yeah, you got a WW. And I said, what? What's that? And he said, it's a whiny woman. And I didn't know enough at the time. Now remember, part of the culture of medical training, and this has gone on for centuries, is that women tend to somaticize their problems. And that there's, we were taught that you always need to look for the psychological reason that she's having these physical symptoms. We weren't taught anything about perimenopause. So here's this woman coming in with a list of multiple kind of vague symptoms, okay, that I now know was probably how her perimenopause presented. Maybe she's not sleeping, she's having some joint pain, decreased libido, right. She's gaining weight, she's, generally not happy, some increasing mental health issues. And that was a WW. Now, no professor ever said that to me. We didn't write it in the chart. It was just kind of a colloquial. I've talked to other healthcare providers who trained all over the States, and it's called whiny gynies. Like this is a thing.
Oh my gosh.
Midlife woman with multiple vague complaints who you automatically start digging for the psychological reason rather than believing her, rather than trying to figure out what's going on with her medically. Yeah. And I had
there's no term for guys.
When I was starting to write The New Menopause, that memory bubbled up, and I was like, do I even talk about this? Is this okay? I'm calling out my own training in the medical profession, but I'm like, I feel like this story is important because it does make me look horrible. Okay. But I was a product of my training as a female coming out of a geology undergraduate degree, going to medical school. I always felt like I would be tapped on the shoulder in med school and told I had to leave. And I had to work really hard and get all straight A's so that I earned my place, right? And residency, I felt really lucky to be at the program and never that I'd earned it. So it's like, for me to have the gumption to stand up for myself was just not happening at that level of training and in my mindset. Now, I'm Gen X now, and I'm like, wait a minute. I'm not standing for this. My daughter's in medical school, and you better believe she's not standing for that. So I think it just creates a reason. It helps explain the mindset of so many healthcare providers.
And I always wonder, there's no term for men like that. I'm positive that there's no term for men. They're like, tell us what's going on, and let's investigate and make sure you're okay. And I heard you say, like, she, what's going on with her psychologically? Oh, it's unbelievable. I'm so happy you called that out, first of all. And I think that's what makes you different, though. And I think that's what makes you special, is that you're not afraid to do that. You've helped. I watch you. I'm one of them. There's so many women that you have helped through just your raw honesty about everything. There are a lot of things that women are learning now, and I think it's good. I think when we started this journey, going out there socially talking about it, a lot of people were saying, nobody talked about it. Nobody is talking about it. Now we're talking about it. One of the big things that I think is highlighted and a concern for women is cardiovascular. And it's something that's almost this like, what? Cardiovascular is a problem we have to think about? It's not new information to you, but I think it is to a lot of women, that this is something that we have to be aware of, so we're not on the other side of it and we're seeing a cardiologist when something happens, that we're being a little proactive in this whole approach. So can you talk a little about that? Because I think that's a big point that you drive home in the book.
I didn't realize the clinical impact of menopause on a woman's risk of cardiovascular disease. That really stopped me in my tracks. And it was the 2020 article from the American Heart Association where they clearly said, we looked at the WHI data and we stratified it by age. And women who were starting hormone therapy around their natural menopause, which is when most women should be starting it, have decreasing risk 50% per year of cardiovascular disease. That estrogen appears to be incredibly protective to our carotids and coronary arteries. And that women on HRT are less likely to die from cardiovascular disease and all-cause mortality across the board. And I was like, wait. Now, and then, you start digging, well, independent risk factors through the menopause transition, insulin resistance, part of metabolic syndrome, hypertension, and increasing cholesterol levels. So here's this woman coming in, 53 years old, getting her annual labs done. And all of a sudden there's a 30, 40, 50 point jump in her cholesterol, especially the bad cholesterol. She loses good cholesterol levels, gains the bad cholesterol. And her doctor is taught and trained to automatically put her on a statin. What that article in 2020 said was, we have no data that shows that a statin is going to decrease the risk of a heart attack or death from a heart attack for women, only for men. Yet we're routinely recommending it to women. A baby aspirin does not decrease the risk of cardiovascular disease in women, only in men. An ACE inhibitor for hypertension, no improvement in the risk of cardiovascular disease in women. Yet this is routinely being recommended to women. They called themselves out, and I was just absolutely floored by that.
Well, I have a question for you. Do you think that women that are should get a cardiologist before something happens? But when do you know that's the right thing to do? Like, there's no benchmark. We've talked about that before. We know we're supposed to go get a mammogram at a certain age. Right. We're now learning that we should pay attention to our hormones at a certain age. Do we go in to find a cardiologist at this certain age too?
So there's yes and no. Definitely if you have risk factors. So if you have elevated cholesterol, hypertension, diabetes, and of course the family history part of it, right? You should be proactive and meet with a cardiologist to discuss what you can do prophylactically to decrease your risk of disease. We're getting better at screening. There is a screening test called the calcium cardiac score. It's a CT scan around the heart where they can see calcifications of the plaques. So when I have a patient who's over 60 wanting to enjoy the benefits of hormone therapy and she's got some risk factors for cardiovascular disease, we are getting that test to see if she's clear in her vessels before we start hormone therapy, because estrogen is better at prevention than cure. And for people who have serious cardiovascular disease in situ, putting you on hormone therapy might make it worse, especially in that first year. So this is a nuanced conversation, and once you're past that 10-year window, we are losing the cardiovascular benefits that we were enjoying in those first 10 years. Doesn't mean it's harmful necessarily, but I can't tell a patient in her mid 60s who's been menopausal for more than 10 years that she's going to have a decreased risk of cardiovascular disease.
There's the three big, things that we talk about. What age you can do with hormone therapy after, you hit menopause, and then what happens after that. You have said, I'm going to die with my patch on me. Like that is going to happen. I am staying on my hormone therapy. I sat next to you on a panel at South by Southwest and heard you say it. I was like, me too. But a lot of women have questions now because they're getting new information and they say, wait a minute, I was never offered hormone therapy. So can I start it now? It's been 9 years. It's been 11 years since I went into menopause.
Your bones will always benefit. Your brain will, if you're in the first 5 years, your brain will definitely benefit. Your genital urinary system will always benefit. Your skin will probably always benefit, and that's the loss of conversation that people are having. They're focusing only on the risks and none of the protective benefits. And I think that's the problem is women are only getting half the story if they're even offered. Actually, probably 80% of women are never given the discussion or the opportunity.
Yep.
But here you're on social media, you're following the Menopause, you're hearing all this great stuff. You can't just walk into your basic OB-GYN's office or internal medicine or family medicine. Right now, we're only churning out maybe 8% of those docs are feel competent in doing menopause care. They know it's important, but they just didn't get the training. So to find a menopause informed provider, the Menopause Society is a great place to start, menopause.org, and look for the certified check, someone who took the test. So that's one place to start so that you can have a really nuanced, informed conversation.
Most important question I think that I get or I hear often is my doctors won't talk to me about hormone therapy. They said to just get through it, tough it out. It's kind of normal. What's the answer? What's the answer a woman has to give back?
It's hard to change someone's mind. They didn't receive, obviously they don't know the latest data, information, and training, and they were never taught it from the get-go. And sadly, the American Board of OB-GYN, at least in my profession, rarely highlights a clinically significant menopausal article. So They're in their CME, they're not really being shown these articles. And so finding a menopause informed provider, get your pap smear there, get your breast exam done, do all the basic screening. But at least for today, you're going to have to go outside. So there's great telemedicine companies who are specializing, and they don't pay me to say this, in menopause care. There's, and then the list of certified providers is another great place to start.
Wonderful. All right. The new menopause. I know women are picking it up left and right. Is there something that you learned in writing that book? I'm always curious.
Oh my gosh. I probably read 2,000 articles for it. A lot of it was driven by 10,000 women on social media asking you the same question, like ringing in the ears. I had no idea. Vertigo, dizziness, absolutely related to menopause. I had no idea. The research on frozen shoulder. I covered the weight gain and the visceral fat changes in the Galveston diet, but, really looking organ system by organ system, all the changes in the brain. Dr. Mosconi's book is so fabulous for that. And I do a brief overview of that. I'm like, go read her book.
Yep. I'm doing that in my book. I'm like, go read Mary Claire's book. But I think it's really important because everybody brings something else to this conversation. Dr. Lisa Mosconi focuses on the brain, and it's a great place. But you're focusing on the overall woman, and I think that's so important.
When I got to the end of the book, several things were solidifying in my mind and happening in my own personal life. My mother. My grandmother spent the last 5 years of her life demented in a bed. And she was in her 90s, and it was a miserable existence. Okay. She was very sweet though. Yeah. And, but for the last couple of years, she didn't communicate at all. And it was just tough. And I was like, I don't want that. And now I'm watching my mother in her 80s, younger, do the same thing. And my mom's been on a walker for 10 years. She was a college athlete, and
so hard to
my sister and I, like the text string with my siblings on what about mom? Do we put her in a home? We're going through all those motions, which we've talked about with our own, families before. And my sister and I are so focused on how do we not do this to our children? We don't want our kids to have these conversations.
Yep.
Or have to have the conversations. How can we limit that as much as possible? And that's what really crystallized for me in writing the book was all of these habits that are all going to work in our favor. HRT is one part of it. But what if you can't take HRT? Nutrition has got to be the first and foremost thing. Moving our bodies, strength training, stress reduction, putting our own oxygen mask on first, not putting everyone's problems ahead of our own, just learning to carve out time for ourselves, for our own mental health. is so important into like getting to that finish line that we want. Yes, we're living longer than men, but 20% of that life is in poorer health than our male counterparts. You can have the 4 years.
I agree with you
I don't
completely.
want to be demented or requiring long-term care. I don't want that. I want to die like our dads do. They live. My grandfather drove a truck and had a heart attack the same day, and died. I just want that, and we have to fight for it.
Yeah, we do. We have to fight for it, and it takes every single voice to do that. And so I get real excited when I see people responding to these posts and these books, and and being aware of that conversation, because we can't do it without everybody, stepping up and also listening, and then sharing the information with their daughters or sisters or whoever it is. If you're hearing this and you repeat something to somebody that you love, I think you're part of this group and making a big difference. You mentioned frozen shoulder. I don't think I've said the word so many times as I have in the last 6 months. And I was watching Palm Royale on Apple TV, and they mentioned frozen shoulder, but it's supposed to have taken place back in like the 60s. And so I was laughing. I'm like, there was no such thing then, but they did such a great job of, bringing what we're all talking about. So let's touch on frozen shoulder real quick, because it's real.
Yeah. So musculoskeletal is part of the musculoskeletal syndrome of menopause, which Dr. Vonda Wright, another of the Menopause I've, she's actually writing a book about growing old strong. Musculoskeletal syndrome of menopause affects 80% of us going through the transition. It's basically your bones, muscles, joints having pain and disability without injury. And frozen shoulder is basically adhesive capsulitis. There's a capsule around our shoulder joints that basically becomes contracted and becomes fibrosed to the point where you can't move it in certain directions. Usually what I've heard, it's hot. I keep testing it, but you can't put your arm around your girlfriend in a picture, That's
what I said. I said, I can't do my picture anymore. So I'm like this next to the person. And I'm like, I really like you, but I can't hug you. I'm so sorry.
And you physically can't move it because the shoulder becomes encapsulated. So there were an OBGYN, head of the OBGYN department at Duke, and the head of the orthopedic surgery department at Duke got together and said, listen, there's a correlation here. There's too many of this happening to women. They pulled the research, did the studies, and saw women on HRT had a much lower risk of frozen shoulder. So the loss of estrogen, the lack of estrogen seemed to be contributing. Do you know they shopped it around to all the ortho journals and it was declined?
Oh my gosh.
Because it's 97% male in orthopedic surgery. So then they got one of the OB-GYN journals to pick it up and they published it. And now it's like talked about all the time. And it's real. So you can decrease your risk. So what my patients are telling, we need more studies, but what my patients are telling me, they get on HRT after the frozen shoulder when they hear all this stuff. And so their next occurrence is shorter and much less painful, and they recover much quicker. You still need physiotherapy. You still need all the exercises, and you can check out Vonda Wright's website for all that. She has
she's great.
And then some people do microneedling. There's, really, really severe cases. You might need surgery to open up the capsule.
Right.
But that's rare. But if you get it, if you notice it, you need to get into a therapist office immediately. Not wait. The quicker you move towards therapy, the faster the process is going to go for you.
Dr. Mary Claire Haver, it's always so good to see you. I know I'm going to see you in a few days. I'm excited, and I'll just do a little brag that you're part of the documentary that we're shooting right now that's going to be on PBS, World Menopause Day. So I'm so happy to have you part of that. I know you just finished up that filming, and I know you've got a big book tour coming up. But I will see you soon, my friend.
Take care.